that Dr. Josephson also serves on our Dean's Council. So he also is a Chief Medical Officer. I already told you guys that at Nemours.
I'll give you a little bit of my background. So I'm the Chief Medical Officer of Nemours Children's Specialty Care here in Jacksonville. I'm a pediatric ear, nose, and throat head neck surgeon by trade. I actually still practice and still love taking care of children and operating and things like that. My area of expertise within pediatric otolaryngology is I'm a sinus and skull-based surgeon, a rhinologist. And that's most of the work that I do. I still do some general stuff. But I also love to teach and love to be invited to do things like this. And so we're going to talk again, like I said, about patient experience. So how many people know what HCAHPS are? We got a few people. How many people know that the way healthcare is going now, consumerism is taking over the market? So do we all know that? So if I'm paying for something, or if you're paying for something, you want to be able to get what you want to get, right? And you want to be happy with the product that you purchase. And today's day and age, a lot of people are now being required to have bigger deductibles, bigger co-pays. And so now they're paying a little bit more attention to the health care that they're getting. And so if I'm going to go ahead and purchase something, I want to make sure I'm getting the quality product that I want. Healthcare is no different. The other thing is that as physicians, we're in a service industry. And for many, many years, physicians thought that they were kind of not part of the service industry in the way that we think about. And when we go to a restaurant, we want to make sure we get a good meal. We want to make sure that the service is good and we're treated nice, right? And the waitress or waiter comes over and greets us nicely and makes sure that they come back and refill our water in a timely fashion. Well, in healthcare, that's not the way it always works, but it's changing, okay? So why does it not always work that way? Because people would come to the doctor's office and they would sit in the waiting room for however, because they just needed to see the doctor, and the doctor felt this is the way it should be. But we recognize that there's some differences or some benefits from giving people a good experience or from patient satisfaction, giving them the satisfaction that they require. So, first of all, does patient experience matter? So as you see from this is an article, actually that's the cover of the Physician Leadership Journal. That's part of the American Association of Physician Leaders, and that came out in November, December of this past year. And now hospitals are recognizing how important patient experience is, that they're actually naming people as their chief experience officer. So they're taking physicians that are good at this work, understand this work and the importance of experience, and they're making them chief experience officers, and some of them report directly to the chief executive of the operations, the CEO. So it is important. It's moving more forward in that regard. So I have nothing to disclose. I just want to mention that. So what's our objectives today? We're going to talk about a few things. We're going to understand what CAHPS is. So when we're done here, you're going to know exactly what CAHPS is, which is the Consumer Assessment of Healthcare Providers and Systems. Those are the surveys that the government puts out that does patient experience or satisfaction. So you're going to understand a lot about CAHPS. You're going to understand patient satisfaction as a quality metric. So as we're moving from volume to value, so we're in a fee-for-service business right now, where every patient I see I get paid for. But what the government wants to do, what the health industry wants to do, is they want to change us from a volume business to a value business, where we keep people healthy. Let's keep them out of the hospital, and let's measure our outcomes. Let's make sure that if we're doing something, that the outcome is good, so the patient's not getting readmitted to the hospital, the patient's not using the wrong medicines or excessive amounts of medicines. So these are all the things that we're going to be considering. We want to talk about what the literature says, so I'm going to keep you up to date. Everything I'm going to tell you, again, I practice evidence-based medicine, so I'm going to tell you things that are in the literature, and that's based on the research that's been done, and that's real important. And then how do I maximize my scores? And so the reason why I talk about that too is I give a lot of these lectures to our physicians and nurses and things like that, and they want to know, how do we improve our scores? If my scores aren't very good, then I'm not going to get reimbursed from Medicare, and the private insurers are following that. And so that's a real important thing. And I tell a lot of physicians, they go, well, this is nonsense, and I'm going to tell you a little bit of a story and history through some of this as we move forward. And it's very interesting to see, many, many years ago when this stuff started first rolling out, I would tell my friends, I went to the Academy of Otolaryngology, I said, I'd love to give a lecture on patient experience. No one wanted a lecture. They said, oh, this stuff is hogwash, it's not going to blah, blah, blah. And then about 4 or 5 years into it, I get a call, the board from the American Academy said, you know, we heard that you're doing some work on patient experience, patient satisfaction. Will you come and give a lecture? So I did. And then from there, all of a sudden, now that payments are coming for patient experience, now the phone doesn't stop. Everybody's, can you come? Can you teach our doctors how to do it? And so on and so forth. So it's interesting. So I'm going to share some of my experiences with that. So the world of healthcare has really changed. And you see all of these, and this is unprecedented changes. When I went to medical school, and I won't tell you when I went to medical school many years ago, I never thought the healthcare environment would look like it does today. Okay? Consumerism, more alignment and infrastructure is changing. We're talking about industry consolidation. More physicians are employed than ever before. Okay? I think it's somewhere around 60 to 70% of physicians are now employed by either hospitals or large groups. Where many, many years ago, many doctors were in private practice or solo practice. You cannot survive in today's day and age if you're in that type of environment with what's going on and how payment is going. So where does this all start? And that's why I'm going to talk to you about the history. Okay? So way back in 2010, President Obama was our president, and he said, we're going to put out the Affordable Care Act. And so what that basically did is it mandated for us to start looking at value rather than volume. So he said we want to look at quality metrics. We want to look at all of these things that are going to keep people out of the hospital, reduce the cost of healthcare, and give us a healthier population. So conceptually, it sounds great. The question is, how do you get there? And that's the journey that we're currently on. The thing about it is this is a law now. Okay, so when we got a Republican president several years later, they tried to repeal it, right? But he wasn't able to do that. He's repealed pieces, but not all of it. And so we're still going to be working through this of how we move forward with the Affordable Care Act as long as it's still working. So here's again a little bit more of the picture. So back in 2015, that's when we used to have the sustainable growth rate. And what that did is every year for Medicare payments, or Medicare Medicaid payments, there was an increase every year to physicians for cost of living and inflation and so on and so forth. And what happened was in 2015, Congress said we're going to repeal the sustainable growth rate, and then we're going to vote in MACRA, okay, which is the Medicare Access and Chip Reauthorization Act. And again, we're going to talk a little bit about that. And basically what they did is they said for the next 5 years, we're going to go ahead and increase payments to doctors by 0.5%. But after 2019, and in all those years, we're going to try to accumulate benchmark data. Then in 2020, we're going to start paying for value. So there's risk now, okay? And that's how that's changing. And so how MACRA works is there's two arms. And again, I'm not going to spend a lot of time on each of these, but I'm going to give you the general understanding of what it is. So how MACRA works is there's two arms. First arm is MIPS. Most physicians are in the MIPS arm, which is the Merit Incentive-Based Program, okay? And it works on four things, which is quality, cost, advanced care information, and clinical practice improvements. And so physicians register, and then they have to come up with these metrics that they then will report to the government, okay? And if they meet those metrics, they have to either meet the benchmarks or do better, and then they get their payment. And that's going to change, and starting with 4%, so you're at risk 4% plus or minus. So if you're below those benchmarks, you lose 4% of your payments from your Medicare reimbursements. So then what they said is that each year we're going to increase that. And so right now they're saying in 2025 it's going to be plus or minus about 9%. And that may change. So that's the MIPS arm. Second arm is the alternative payment models, which are ACOs. So what ACOs are is basically big hospital systems that have all the services that are necessary and can take care of patients from birth to death. They can actually apply to be an ACO, and then basically it's almost like a big HMO where you get all your care from them, and they have all the specialists and things like that. And if they meet the metrics that they need, and that includes some of those quality metrics that we talked about, they get some additional payment. Okay, so that's the ACO model. Individual physicians or physicians that are in groups, they don't have all the specialists, they don't have all the primary cares, so they're not going to be able to be in an ACO. Okay, does that make sense? Terrific. So in the end, when the government put this all together, they said, guess what? we have no more money. So you can either give high quality for a lower cost. We think that if you give great quality, it's going to decrease cost. Or you can continue to give low quality for a higher cost, but at the end, we're not paying any more money. So this is it. This is what you're going to have to work with as far as the financial incentives. So, anybody know what the Institute of Healthcare Improvement is? And I'll tell you, you guys should go online to the IHI.org, the Institute of Healthcare Improvement. They actually have something called the Open School, and you can actually take free courses through the Open School. And what it does is they talk to you about quality and safety. And they talk to you about where this all started, which is crossing the chiasm, where the Institute of Medicine came up with the reports back in the late 90s to show how many patients died in the hospital. And they said somewhere between 49 and 98,000 patients were killed every year from bad care, wrong drugs, and things like that. And that's where, again, a lot of this stuff came from. They said we have to figure out a way to do better in medicine. So the Institute for Healthcare Improvement, they came up with something they called the Triple Aim. They said what our goal is number one is we're going to improve our patient experience. But the patient experience is not just about making you feel like you got a good experience. It's also increasing the quality, because if you get good quality, that also improves your experience, correct? Second thing is we're going to improve health populations. And a lot of things that we're talking about now is population health. And what population health is that we're going to take populations of people and keep them healthy. We're going to keep them out of the hospital. But we have to have buy-in, where you say, you know what? I am going to eat right. I'm going to exercise. I'm going to do all of these things so that I don't get sick. And that's a whole different concept for physicians. Physicians have always made people better. Do you know what's interesting? The white coat that a physician wears, in the old days, in the 1800s, physicians came in black, not in white. White was for lab techs and other types of pharmacists and stuff. The physicians were in black because we didn't really have any cures, and usually by the time the physician got called, the patient was about to die. And so typically, or traditionally, back in the 1800s, that was the garb that the physicians wore, was black. So anyway, they're saying improving the health of populations. And then the last thing is we're going to reduce the per capita cost of healthcare delivery. And then very important is, several years ago, what it was recognized is that, number one, we have a shortage of physicians. That's a whole nother lecture that we can give, is why we have a shortage of physicians and the economics of that. Because back in the 90s, when I was finishing my residency and things, they thought there was going to be a surplus of physicians at this time. But we found that there's a huge shortage. There's a big problem with physician burnout. Has anybody heard that term, physician burnout? Okay, so we're asking physicians to do a lot more. A lot has to do with the computer system and information and things that are available and how quickly things are running. And so because physicians are having to do more, they're burning out. They're getting tired, and we have to make sure that our physicians stay well so that they can continue to do the great work that they're doing. So now they call it either the quadruple aim or the triple aim, because they say that is part of our aim, is we also need to make sure that our physicians and our patients, physicians and our providers are healthy. So patient satisfaction, what does that mean? Okay, so many, many years ago, like I said, when I first embarked on this journey of teaching this kind of work, is I asked, my colleagues, I said, so, what's patient satisfaction? What do you think about that? Because many of them didn't want to buy in. And they said, it's hogwash. Listen, let me tell you, I'm a good doctor, okay? They said, my patients get better. If they don't get better, they're probably not following my advice. They're not taking their medicines, or they're doing some of the wrong things. But this whole patient experience thing is hogwash. But that's what they thought. They said, I have good outcomes. So I'm going to show you a little video here, a little bit about and again, this is going to be a little exaggerated, but what do people want in the millennium? Okay, we're dealing with consumerism. What do people want?
I am my car. I am my clothes. I am my bank account. I am my house. I obey my thirst. I have it my way. I just do it. I deserve a break today. I double my pleasure, double my fun. I live the high life because I'm worth it. I'm looking out for number one. I wait for nothing. I have a million choices. I get what I want. I do what's best for me. I spend my time where I want to spend it. No one wastes it but me. I have the world at my fingertips. If it doesn't work, I'll throw it out and get a new one. If I'm uncomfortable, I leave. There's another place just down the street. If I'm unhappy, I'm missing something. I find it. I buy it. If I want it, I get it. I accumulate. I collect. I acquire. I take. I use. I devour. I consume. I am not the center of the universe, but I'm the center of mine. I want to know what's in it for me. I want to know what I get out of it. I'm here to find happiness. I live for comfort. I exist to be served. The world exists to serve me. I am the customer. The customer is king. I am king.
So the first time that I showed that video many years ago when I was teaching about patient experience and patient satisfaction, I actually had an old-time doctor who was a cardiothoracic surgeon and was actually very good at the work that he did. He actually got up and he said, "I'm not listening to this," and he walked out. Okay? And I said, well, I didn't mean to offend you, but we're changing. The world is changing and we have to understand why. And again, as I said to you from the very beginning when I first was standing up here, I said medicine is a service business. I always tell the people that work at Nemours, I always say, it's yes, how can I help you? And even more so, we want to make sure that we take care of our patients. We want our patients to be happy and we want them to get better and we want to be available for them if they need us. I mean, that's what we're supposed to be, and we're a service business and we're going to be successful if we can provide that. So what is patient satisfaction or patient experience? First of all, I can give someone a bad experience. So you have to understand what the expectations are. So if you understand what someone's expectations are, then you know what kind of experience that you can give. And so that's how we know what good patient satisfaction is, which is really good customer service. So again, we're going to go back to when I said, when you go to a restaurant, do you want a good meal or a bad meal? A good meal, right? And you go to the restaurant because you don't want to pay the bill if the meal is terrible, right? And you want the waitress or the waiter to treat you nice, right? So when they come there and you get your service, that's what you're paying, right? Otherwise, you don't want to give them a tip. You're certainly not going to give them 20%. You may give them 15%, right? If they're not as nice, you may not want to give them anything. But obviously, I know all of you would give something, right? So let's think about that. And this is a whole new concept for medicine. So I just want you to think about that. So then the thing is well, you can say all you want. But patients don't know the difference. They'll wait for me because they want my service. There's a shortage of physicians. But guess what? They're also being educated. So this came out from Parade magazine. And what it does is it says here, I was thumbing through this about 2 or 3 years ago when it came out. It's asking, how long should you wait in the waiting room? It says, can you ask your doctor for a discount? I mean, think about that. That's what it says right there in the corner there. Okay, I don't expect you all to, well, go ahead and read this. No, I'm kidding. So that's the thing that you have to think about is that consumerism is here and expectations are now starting to be set. So when it says there that you shouldn't wait more than 10 minutes to the doctors, and you've read that in this magazine, and you go to your doctor and you wait 20 minutes, are you going to be happy? No, I just read something that says it shouldn't be more than 10 minutes. Okay? And with the way the world is working, these expectations are changing. Okay? I'm going to show you some other interesting things. The other thing is, so doctors say, okay, so look, they don't have any other choices. Who else are they going to see? So they'll wait, right? But look at this. This is something I picked up at Walgreens. So CVS is not CVS Pharmacy anymore. It's CVS Health. And now they merged with Aetna. There's all these big conglomerates that are not really in healthcare, do not employ physicians, that are getting together and getting into the healthcare space. And so what does it say? It says, we keep your doctor in the loop, but you can come to us and we will give you your flu shot. That never happened 10 years ago, right? Or 15 years ago. You went to your doctor for your flu shot. You went to your doctor for a strep test. Now you can go and they have a nurse practitioner or a PA swab, and then they go ahead and call telemedicine, and you get a telemedicine doctor, and they'll go ahead and call in your prescription off of your iPhone, right? So you don't even have to leave your house half the time. So isn't that an interesting change? So there's competitions there. Transparency, and again, I'm not expecting you to read all this, but I just wanted to show you. So here it says, patients can view online reviews from other patients. How many people have looked online for a review for a product you wanted to buy? Pretty much every one of you, right? So you're thinking that you want to buy a new, new rug from some place, and You go online, you see what other people, or you want to hire a new contractor to come to your house, you need a plumber to come to your house, you're getting online, right, and you're seeing what other people say. And how many people are influenced by that? If you see someone who has 2 stars out of 5, are you bringing them into your house when the next few have 5 out of 5? So that's what's happening in medicine now. Okay, not only is it happening in medicine from the government or from the insurance payers that are sending out these surveys like Press Ganey, or the HCAHPS or the CAHPS surveys that I was sharing with you. I'm going to talk a little bit more about that. But now you can go to WebMD. People just go in and they're going to go ahead and do a review. So is that important? Well, there's 40 to 50 online sites now that do physician reviews. Okay? So if I'm a physician, I'm going to be a little concerned now about this, because now I've got to think about, if I treat someone poorly, what are they going to write? Now, if you have 1 bad review and you have 10 good ones, most people are understanding. I mean, when we look online for things that we're looking for, and actually there was a study that looked, people actually like to see some unfavorable reviews sometimes because we're human. And so if you got some 3 out of 5s, but everything else is 5 out of 5s, you're like, that person's human. That's okay. Okay, so 40 to 50 online sites, those are some of the more common ones. In healthcare, 25% of U.S. adults consulted online in 2012. Greater than 75% of adults now go online before they pick their physician. Okay, I'm going to show you something else that's interesting. In this chart here, 62% now, it's the first step in picking a doctor, they go online and look at reviews. All right, you know what's even more interesting? And the second thing is 19% of patients, they go online to see if they should keep the doctor they've been taking care of for all these times, and they may switch. So now the information's out there. I've been seeing Dr. Josephson for 10 years. Maybe he's not all that good. So I'm going to look online and see, should I change? Or some people make an appointment and then they go online and see, should I keep that appointment, or do I have another choice? So consumerism is coming out there. So the good news is that overall in the healthcare space, most physician online reviews are positive. There are some bad ones, most of them positive. And there has been, in some of the research that's shown, this shows that there is a high correlation with the quality of care that you're going to get and what the reviews are saying. So if you got someone who's gotten all 5 out of 5s, then likely when you go there, you're going to get good quality service. So I decided to look online myself a few years ago. I said, well, I'm going to go ahead and look online. Let me see what my patients are saying about me. And thank God, 6 reviews. Woo-hoo. 6 reviews, I'm 5 out of 5, so I felt pretty good about that. And I looked in there, and there were some nice comments, and I said, I'm doing okay. More reviews now, and you guys are welcome to look, but I thought that was good and important. So I still have physicians that tell me that they don't care, that they don't think that this means anything. And again, it does. So back, again, in 2002 at Nemours, when we started using Press Ganey surveys, we decided that we need to incentivize the things that we want to produce. And so we actually made patient satisfaction scores through Press Ganey part of their compensation for bonus compensation. So if you don't meet these metrics, guess what? You're not going to get your full bonus payout. So ouch. Now they start listening. Okay? Well, that was just what Nemours did for our physicians, because we wanted to lead the way, and that was early on. But that's what's happening now with the HCAHPS. That's what's happening with MACRA. Is these are quality metrics, and you're dinged for 2020, next year, plus or minus 4% of your payments if you're meeting these metrics. And patient satisfaction is one of the quality metrics that they're using. Yeah?
What is the percentage for the bonus part and the salary part for physicians and units?
Well, so that depends. So we have a number of different plans that we use at Nemours. So remember, there are physicians that are hospital-based. So we have actually we have compensation plans that are hospital-based because they don't have the ability to get more business. So if I'm an anesthesiologist, right, then whatever the surgeons bring to the hospital is what I get. And so I can't influence my volume of patients. So what we do with plans like that is they have a base salary, and then we have what we call a 10% plan. So they have 2.5% of their bonus compensation is based on satisfaction, because they do get surveys. Part of theirs is meeting quality metrics, so maybe about 5% to say, on-time starts, no returns to the OR, things that they can influence in that regard. And then there's a 2.5% that is discretionary, at the discretion of the division chief and the department chair, to say, you've written some papers, you've gone above and beyond. So that's the 10% plans that we have, mostly for our hospital-based practices. For our outpatient type of practices, they are incentivized partly by productivity. So we say, here's your threshold, here's your salary, this is your threshold based on a conversion factor, and I'm sure many of you have heard of RVUs and things like that. And once you meet your threshold, every dollar you get over the threshold, you get to keep some of that money. And then the second portion of that is for quality metrics, and the third portion is for patient experience, is what we had done then. We've changed that a little bit over the last year, because now we're starting to try to incentivize some other things, not that patient experience or quality. We're kind of lumping quality and safety in with patient experience, because we do believe that's part of it. But now we're starting to move some of the incentive towards publications, because we want Nemours to have a larger academic presence. And so that's what, so you incentivize what you want to accomplish, right? So that's what we want to do. So our physicians weren't very happy about it. But when I think about this, and I've talked to my docs all the time about this, I said, let's think about what we want in healthcare. What would I want out of healthcare if I was getting treated myself, right? So I do want quality healthcare, and I want good outcomes. I want to get better, right? I want a reasonable cost, especially if a lot of that's coming out of my pocket. I want access. I want to be able to get in when I need to get in. I want convenience. I'll use my cell phone if possible, have convenience to talk to the doctor. I want knowledge about my disease. I want to know about what's going on, what my outcomes are likely to be. And I want empathy. That's one of the big things, and we're going to talk a little bit more about that shortly. So that's what I believe that I would want for my patients. I think that's what doctors want for their patients. Matter of fact, Nemours has a true north. True north is like our vision statement. And for our true north, we say, help me receive exactly the care I need and want, how and when I need and want it. Okay? So, again, thinking about consumerism and those things. So, understanding HCAHPS, we talked a little bit about HCAHPS. So, the CAHPS, what does CAHPS mean? It's Consumer Assessment of Healthcare Providers and Systems. These are surveys that were produced by Medicare and Medicaid. They capture feedback only patients and caregivers can give, right? It's a survey. It's used to produce comparable data for public reporting. So this is another thing. As I showed you, you can go online and you can look into health grades and you can pull up doctors' names and stuff. But this is the government's part. And you can go into the government website, which I'm going to show you, and you can see all the physicians that are listed there. And it enhances public accountability and transparency. Why HCAHPS? H stands for hospital, so that's why it's hospital CAHPS. But now they've developed surveys, and these are some of the years that some of the surveys have come out, but now they have surveys by dialysis centers, they have surveys for emergency departments, outpatient departments, surgery. Pediatric HCAHPS came out in 2015 for the hospital, so there's more and more surveys that are being developed. But now what's happening is not only is the government making their own surveys, they're now allowing some survey producers like Press Ganey, for instance, that they can actually have an account and say, if you use Press Ganey surveys, this will work as well and be sufficient for grading. So again, we're talking about getting value-based, and patient experience is part of value-based. It was expanded to all physicians in 2017, unless, there are doctors out there that do not see Medicare or Medicaid patients. So if you don't, we can't judge you, right? So you can do that if you can survive in this world with that, and not many can. It's 4% and then going up. There's two categories now, so they expanded the categories for patient experience. It used to be only in the quality category, but now it's considered a clinical practice improvement category. So there's two categories of those four that patients' satisfaction scores can be used for. Has anybody ever gone into the website www.medicare.gov? So I would recommend all of you getting your master's in healthcare administration, that you go into the website and just kind of cruise around it, and you'll see the different things. If you go, there's two things. One thing that's called Physician Compare. All the physicians that take care of Medicare and Medicaid patients should be listed in there, and their metrics are being now put in there, so for full transparency. But also Hospital Compare is in there. And so all the hospitals in Jacksonville that take those patients, which is all our hospitals in Jacksonville, are listed there with different stars and stuff like that. So this is interesting because it's not just for looking at your scores and stuff. It's also to educate the providers about what we're doing. So I'm going to show you this video that you can pull up on that website. And this is how patients can access.
You take care of yourself. But sometimes you need to find a doctor. That's why Physician Compare is here for you.
Welcome to Physician Compare, a website created by the Centers for Medicare and Medicaid Services, or CMS. All physicians and other clinicians listed on Physician Compare take part in Medicare, and there are 3 different ways to find the information you need. Let's take a look at how Linda, Mary, and Don use the Physician Compare website to select their doctors.
So I only put the third one, and I'll show you why.
Let's see how Don uses Physician Compare. Don's primary care physician wants him to see a cardiologist for some chest pain he's been having recently. He's having difficulty spelling cardiologist, but then he sees the Browse by Specialty button. Don selects the letter C at the top of the page, and it automatically takes him to all specialties beginning with the letter C. As he goes to pick cardiology, he sees that when he hovers over each term, a definition appears to explain what the specialty is. Don selects cardiology and is redirected to the results page, where he sees a list of available cardiologists in his area. He chooses a group. He notices that this group accepts Medicare assignment and has performance scores available. Don also sees that this group has patient survey scores. He chooses the tab. These scores are based on information patients reported about their experiences with getting care from the group. Based on the feedback, Don decides this would be a good group for him to visit. He's glad this website was able to provide him with vital information so he could make an informed decision to improve his health.
So
quality health care is important for
an informed decision based on patient experience scores, which it is, it's important, but there's so much more to it than that, obviously. And what's interesting is this said he picked a group, but individual physicians are listed. And again, as you peruse in your spare time and look around, you'll see all the physicians that are on there, and they're starting to load the data in from those physicians. So what are the survey types? There's 2 types of surveys out there. There's behavioral-based and there's perception-based. So what perception-based is 1, 2, 3, 4, 5, from very poor to very good, okay? Behavior-based surveys are something as is never, sometimes, usually, and always. And so Press Ganey, their surveys are perception-based. The government surveys, they're behavior-based. And I mean, again, I'm not a psychologist, but I think that behavior-based gives a little bit more leeway. What's interesting is on the perception-based for Press Ganey, 4 out of 5, which I think is actually pretty good, is a fail. You have to get 5 out of 5 in order for you to get credit for your reimbursement. So I wanted to show you, this is the surveys that the government put out. And again, I don't expect you to read this, but what's interesting is this for emergency room surveys. And when they came out with emergency room surveys, they said, well, we admit some of our patients, right, after the emergency room, and we don't want to get a bad score. So they said, okay, we'll make another survey. So they have one survey that's hospital and emergency room patient survey, and then they have another survey that's emergency room survey only. So now, depending on if you stay or not, it depends on which survey you're getting. Again, more surveys are coming out there. And again, this just kind of shows you some of the questions. So during this emergency room visit, how often did doctors explain things in a way you could understand? Never, sometimes, usually, always. Okay, behavior-based survey, hoping that you get always on all of them, right? So just an example of that. So what does the literature and the research say about this? So again, 10 years ago when this stuff started to roll out, everybody said, this stuff's hogwash. There's no research to support it. It's all completely subjective. And why should I do this? The literature's coming out more and more that it does give better health outcomes. Why is that? Number one is, if your patient likes you, they're probably going to listen to you. If they walk out and they don't like you, they're probably not going to take their medicine or do what you tell them. So that does give better health outcomes. So increase activation of our patients. Reduces liability. There is tons of literature out there that shows if your doctor likes you, or you like your doctor, and something goes bad, there's a bad outcome, and a lot of times doctors don't get sued because they did malpractice. Sometimes they get sued because the outcome was bad. And that does not necessarily mean they did something wrong. But it's less likely, if the patient likes you and has a good relationship with you, it's less likely they're going to sue you, right? So definitely decreases liability, better healthcare experience, as we talked about. It increases loyalty. So, what do you say? You say to someone, I have the best doctor in the world. You're looking for a doctor? You need to go see Dr. So-and-so. Okay, so it builds referrals. It gets you more patients. Again, part of consumerism and doing the right thing. And lower healthcare costs. And I think that's the thing that we're now trying to investigate. The literature is probably the least populated by articles that say it definitely reduces cost. But it would make sense. If patients get better, they come visit the hospital less often. If you're a diabetic and you take your medicine, you listen to your doctor, you're not going to come into the hospital and, sugar sepsis, whereby, you have to get admitted or something like that. Or if you've had an operation, you follow your doctor's orders, the less likely that you're going to return to the hospital with a complication from that. So those things are all important. So again, and I'm going to keep on going, this is experience. A lot of this has been experience. That's why I say this is a part of my journey. So I'm a scientist, so when my docs, like I said, I run Nemours here in Jacksonville, and I'm responsible from my board and from my CEO and stuff, and they said we want good patient experience scores from your doctors, and we've given you some of the tools by giving some incentive payments and their bonus and stuff like that. And then my doctors would say to me, listen, Gary, they call up, and the lady on the phone is not so nice to me. That never happens at you, right? Never. Not so nice to me. They're never going to give me a score. I could be the nicest doctor in the world. I'm not going to get a 5 out of 5. And I said, I'm not sure I believe that, but okay. Or they say, if they're waiting in the waiting room for 10 minutes or 15 minutes more than they planned on it, I'm never going to get a 5 out of 5. So, like I said, I'm a scientist. I like to do research and I like to look at things. So I said, okay. So I pulled all of the surveys, well, I didn't personally, I had some help, but I pulled all the surveys that we had, over 1,000 surveys. And what I did was I correlated likelihood to recommend with every question on the survey, okay? So clearly you see on the top here, likelihood of recommending the practice is going to be 100% because you're correlating likelihood to recommend to likelihood to recommend, right? So I went down, and on the surveys, the Press Ganey surveys, there's different areas. So there's one area called the care provider section, which is the 10 questions that the physician is responsible for. Did your doctor explain to you your medicines, blah, 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 so on and so forth, those kind of questions. Did your doctor listen to you, and so on and so forth. And so I took all the questions, correlated it with likelihood to recommend, and this is what I found. I found that the green boxes that you see there, the top 10 highly correlated with giving a 5 out of 5 for likelihood to recommend out of 13, we all came from the care provider score. So that tells me that if you love your doctor and you wait 30 minutes in the waiting room, you're getting a 5 out of 5. And so this proves it. And we looked at over 1,000 surveys, every single division. And we actually published a paper about it for pediatric ENT because I got so excited about it, I started doing each individual. I'm like, let's publish this. So we did that for pediatric ENT. We published it in the Laryngoscope in last January, showing that the care provider score really had the most influence on giving people a 5 out of 5. The other thing I thought that was really interesting is how well staff worked together to care for you was number one, highest correlation. So this is very interesting. I'll tell you a little story is that we had this doctor, great doctor, and this doctor's scores were not as good as I thought that they should be. And so I decided to go to the clinic and observe, right? So that's something that if you don't know what's going on, don't understand, then you'll never know what's going on, never understand. So you have to actually go down and watch, observing. I mean, I go sometimes to some areas in our clinic and I'm just standing there and I'm like, what is Dr. Josephson doing here? What is he watching? What is he counting? He's taking notes. But it's all good because, again, I'm trying to make sure that flow, process, everything works well. So I decided that I would just come and observe this physician. Well, I noticed when he walked in the room, he was a little frustrated. The first thing he said is, the computer never works. And I've been asking Jane all the time to come and load these things in and never wants to do it. So what is your patient hearing? This place is terrible. They love the doctor, but his scores were great, but all the other scores were negative, and so likelihood to recommend was not 5 out of 5. So I said, look, this is a team sport. So what happens is I tell the nurses, I said, listen, if the doctor's running behind, stick your head in the room and say, hey, listen, Dr. Josephson is the nicest guy in the world. He's a great doctor. You're very lucky to have him. He's running a little bit behind. But you're going to see, when you meet him, you're going to be very, very happy. We got to up our staff. I gave this lecture to our ER at Baptist, and one of the nurses actually came up to me after, because I told them, I said, if your doctor's running late, or I told the doctors, if the nurse has got something going on, just go and tell, Nurse Mary is awesome. But she's got 3 patients today that she's taking care of, and 2 of them are very, very sick, and she cares about you. And she's going to be in here shortly to make sure that you're taken care of as well. But because of these emergencies, I hope you understand. I've never had a patient tell me, I don't understand, I want to be taken care of now. People are good, right? So they understand that. So we need to up people. So again, what makes me the expert of this? Okay, so this is very interesting. So again, I'm a scientist. I'm interested. I want to know. So when this rolled out in 2010, I said, I'm a good doctor, right? I got good outcomes. Well, maybe not. So again, I don't expect you to read all these numbers, but here I am. There's the national benchmarks. 2010, when we rolled it out, I was at the 54th percentile for national benchmarks. And I said, I am better than 50%. Matter of fact, I was 48th percentile compared to my pediatric colleagues. And I said, well, I'm doing something wrong, And so I went and I pulled the survey out. So it was like an open book test. I wanted to know, what kind of questions are they asking? One of the things that I wasn't doing so well on was I wasn't explaining medicines. I'd give a patient some Augmentin, which is an antibiotic, and I'd say, take the Augmentin, this is how often you take it, so on and so forth. And then I said, never told them that it can cause diarrhea. Make sure you take it with food. Just a few other words that actually, okay, so little things like that. So in 2011, became 84th percentile nationally, 90th percentile against my peds colleagues. 2012, 92 percentile nationally, 99th percentile according to my peds colleagues. 2013, 99 to 99. 2014, 99, 99. 2015, I've been in the 99th percentile for patient experience for the last 10 years. So that's why I'm the expert on this. That's why I'm able to stand here and talk to you and say, I did it, so you can do it. So when I give this lecture to doctors, I say, I'm no better than you as far as being a person. But if I can do it, you can do it. Follow these instructions, and you're going to be successful about it. And again, it works. So what again is patient experience or patient satisfaction? Understanding the expectations, giving them those expectations that they require, and then, or exceeding them if possible. And I call that the wow factor, and I'm going to show you some of the things I do. And then, again, that's good customer service. That's the bottom line. We're in the service industry. So I'm going to share this little movie with you.
Can I help you? Name, please.
Seinfeld. You made a reservation for a mid-size, and she's a small. I'm kidding around, of course.
Yes. Okay, let's see. Oh, I'm sorry. We have no mid-size available at the moment.
I don't understand. I made a reservation. Do you have my reservation?
Yes, we do. Unfortunately, we ran out of cars.
But the reservation keeps the car here. That's why you have the reservation.
I know why we have reservations.
I don't think you do. If you did, I'd have a car. See, you know how to take the reservation, you just don't know how to hold the reservation. And that's really the most important part of the reservation, the holding. Anybody can just take them.
Let me speak with my supervisor.
Here we go. The supervisor. You know what she's saying over there?
What?
Hey, Marge, see those 2 people over there? They think I'm talking to you. So you pretend like you're talking to me. Okay, now you start talking.
Oh, you mean like this, so it looks like I'm saying something, but I'm not really saying anything at all?
Okay, now you say something else, and they won't yell at me because they thought I was checking with you.
Oh, great, I think that's enough. See you later.
I'm sorry, my supervisor says there's nothing we can do.
Yeah, it looked like you were in a real conversation over there.
But we do have a compact if you would like that.
Fine.
All right. Well, we have a blue Ford Escort for you, Mr. Seinfeld. Would you like insurance?
Yeah, you better give me the insurance because I am going to beat the hell out of this thing.
So again, he's not satisfied. So he's going to put bad reviews online. He's also going to treat the car poorly, right? Get a bad meal at the restaurant. You're not going to refer your friends there, right? But now you go to a doctor, he's nice to you, pays attention, gives you the care that you want and you need. What are you going to say to your friends when they need a doctor? Okay? And are you going to listen to them? Yeah, you're going to listen to them. So when I was in medical school, we used to talk about the 3 A's. Ability, availability, and affability. Has anybody heard those 3 terms with this regarding medicine? So when I was in medical school, they used to say, if you have the 3 A's, you will be the most successful doctor there is. If you're able, if you're available, and if you're affable. And we always talk about bedside manner and stuff like that, right? Well, in today's day and age, when people know all the years of training that that doctors go through between medical school and residency, not that we didn't do that then, but we do that now still, they think ability is a given. If I go to you and I need to get better, you're going to get me better because you've had all the training in the world, and so that is out of the picture. So number 2 is availability. I need an appointment. I want an appointment today. It's part of consumerism. I want to get in today. I want to get in tomorrow because that's convenient for my calendar. And again, one of the things that's becoming much more, and actually this is part of the wave of the future, is telemedicine. Now from your iPhone, you can call some of these sites if you have an urgent emergency. You don't have to go to the emergency room. You don't have to go to a care spot or one of these doc-in-the-box type things. You go on your phone. You do that, you see the doctor does an examination, limited to some degree right now, although now there's devices that are out. There's something called TitleCare, which is a company that makes devices that you can buy the kit for about $300. You plug it into the computer, you can hear your heart. You can listen to your lungs, respirations. It has a device that goes in the ear so the doctor can see the eardrum. Looks in the mouth, you can see the throat. It actually has these markers so that the family knows exactly where to position the device when they're opening the patient's mouth to look at the back of the throat for the doctor. So we have those. Now right now that's $300. $300 is actually probably pretty costly for most people. But as you know with technology, right? When I bought a monochrome monitor computer, leading edge. Anybody ever heard of leading edge, right? That's how old I am. So leading edge, monochrome monitor computer, and a dot matrix printer, okay, and it was slow as could be, but then that was the thing. I paid $2,000 for that computer when I was in medical school. And so now, I mean, you can get stuff. So $300 now, it's probably going to be $25, or the insurance companies may give it to you. Say, you join our insurance company, you get this, and then you need telemedicine, go ahead and make the call. You already have the device. It's going to save them money because it's cheaper to call a doctor on your phone or on your computer at home than the patient going to the emergency room, right? So they want to save money. So affability is the big one. That's the one that patients are now looking for now. They want empathy. They want their doctors to care, okay? And actually, a lot of doctors have a hard time with that. Not that they don't care, but they just don't have that caring compassion that patients want. They're getting better. They're getting better. There's a lot of training about that, which is kind of interesting. We're going to talk about that. So this is very interesting, is that back in also the early 2000s, maybe mid-2000s, Harvard University, they did something called the Picker study, where they called the 8 dimensions of care. This was through Harvard, but the National Research Institute. And they took thousands and thousands of surveys of patients, and they said, tell us what you want out of your doctor. Okay? Tell us what you want out of healthcare. And what's interesting is they wanted respect. They wanted respect for their care and things like that. They wanted coordination and integration of their care if it was necessary. They wanted information and education about their disease or their problem that they were having. They wanted physical comfort. They wanted emotional support. They wanted involvement of their family and friends if they've chosen to do so. They wanted continuity and transition, so continuity care or transition if I need some other type of care or a different doctor. They wanted access to care. Does anybody see on this list, it say, I want you to get me better. Isn't that amazing? Now that doesn't mean they don't want to get better. They think if they're going to the doctor, you're going to get them better. This is what they want. This is what they're asking for. And so I've got another little video for you to enjoy. This talks a little bit about empathy. So I share that with you because we don't always know what people are going through, and so they may be reacting based on something that we don't know about. So I'll pick on you. I'm Gary. What's your name?
Amanda.
Amanda. Do you have a good day today?
I do not.
You do not. Okay. Let's go ask someone else here. It's funny. I was driving this morning to work, and I went into the right lane, and the guy that was behind me felt that I may have been a little too close, and so he made some gestures which I wouldn't repeat, and I just figured he must have had a bad day, right? So tell me, did I have a bad day today? Besides that, then, because that didn't bother me. Yeah, no. I had a great day, so thank you. I was had a great day, so thank you for that. But that's my point. My point is I've had patients that have come in to my office, and they had a family member that passed away, or they had a bad experience with something. I've had patients actually that made the appointment, amazingly enough, and had a car accident on the way to my appointment. And so how do you, they have to go, I have to see the doctor. I've got to get this appointment. And they'll do anything to get there. And we're rushing sometimes because we have so many patients we want to see. But we don't always take that moment to say, what's going on? And so I came up with this. So it's interesting. And actually we made cards, which a lot of our doctors used to keep in their pocket. And I've given this out before. We made plastic cards out of this. So I call it the wow factor for improving patient satisfaction. Now this should not only be from physicians. I expect this from my nurses. I expect this from our administrators. I expect this for everybody in healthcare to give that wow experience, that better experience than, so when the parent or the family goes out, they say, I want to come back here. This is the best place to have my child taken care of. So whenever I walk in the room, whenever anybody walks in the room, they should introduce themselves. You shouldn't walk in and just start taking care of the patient. Who are you? Okay? Introduce. I also ask around the room. So a lot of times, being a pediatric specialist, a lot of times not only is mom in the room, sometimes grandma's in the room. Sometimes the sister's in the room. So I make sure that I introduce myself to every person, say, who's this? Who's this nice person here? Who's this pretty lady here? Or something like that, okay? I want to engage all of them. Number 2, connect. I'm always looking at my patients to see if there's a connection. So I may ask them, so where are you from originally? You're from Jacksonville. Oh, no, I'm from New York. You probably couldn't tell I'm from New York. So then I said, yeah, I'm from New York too. So I'm building that connection. How do we pick our friends? How do we pick the people that we associate with? We want to find a commonality. I'm not going to, if I can find nothing in common with any of you, I'm probably not going to be your friend because I have nothing in common. I'm sure I can find something. But that's how we pick our friends. That's how we pick the people we want to be around, is people that have commonality. So I look to connect. I try to find them. If they're wearing a Jaguars jersey, I say, well, I'm not a Jaguars fan because they've been terrible for so many years. No, I don't see that. The Jaguars are awesome. But anyway, so I say, yeah, are you going to go to the game? I try to connect. That's very important. I provide. And as I'm providing my care, I am letting them know what I'm doing. So I'm looking in Johnny's ear and I tell him the eardrum looks good because they can't see the eardrum. Only I can see it. Sometimes even ask, would you like to sing? So I'm providing the care, but I'm explaining to them what I'm seeing. So this way they hear it in their mind, okay? And then I explain everything and then I ask, do you have any questions about that, okay? Then I review. At the end of the whole thing, I say, Johnny's got this problem. This is what our plan is that we're going to do. Do you understand? They say yes. And then I confirm. I ask them again. I say, did you understand? We need this medicine twice a day for 10 days with food so he doesn't get tummy ache and diarrhea. We understand. We're good. Okay? Then I conclude and I ask for more. I always ask at the end of the visit, I always say, is there something that I didn't touch on today? Most of the time they say no. But I have had some patients say, I'm glad you asked, Doc, because you took a look at this. This was the main problem, but this is what else was going on. Can you help me with that? Okay? So I always ask, is there anything else that I'm not touching on? And I always thank people. I always want to thank people. I want to thank them. Number 1 is they have choices. They can go somewhere else. So I want to thank them for their time, thank them for coming and seeing me. I'm also always making sure that if I'm behind, I apologize. I say, I'll walk in the room, I say, I apologize, I'm running a few minutes behind. I hope that you understand. But I'm going to give Johnny the same care as I give everybody, and you can have as much time with me as you want. This is your time. And so when you do those kind of things, those are simple things, you connect, and the patients want to come back to you. And I call that the wow factor, and I ask all my providers to do that. So what did we learn today? That the consumer assessment of healthcare providers, so you all know what CAHPS is now, right? Raise your hand if you don't know what CAHPS is. You bet, because I'll start again. We'll start this lecture from the beginning. So those are the surveys that are developed from CMS, and they're approved to be used. They're transparent. They measure both inpatient and outpatient services. They account for incentive payments and fulfills 2 categories now, which is great. And the percentages will change over time. It's already changed. Even before they've rolled this out, they've changed some of those percentages as they're getting closer to the actual delivery, which is 2020. It's right around the corner. And it's transparent and visible, and like you said, you can go on that website and see those things. What is patient satisfaction? It's understanding the expectations, right, and then delivering on those expectations or exceeding them, obviously, for good patient satisfaction. It's the soft attributes. We talked about empathy and things like that. It's clearly been linked to improved patient outcome and patient care, okay? And then it increases our physician and provider satisfaction. So I a lot of times ask my docs when I'm giving this lecture to doctors, I say to them, how many here hate when the patient comes in with a card thanking them for the work that they've done? Or how many doctors here hate it when the doctor says, Dr. Jones is the best thing since sliced bread. He's the greatest doctor. We love Dr. Jones. She's amazing. Do you hate that? We all love that, right? Don't we love compliments? Of course we do. Why wouldn't we? We're human, okay? So that's what we want to do. We want people to feel that way. And so this stuff actually pays back to our providers, because when our providers do good care, that's what they get back from the patients. They say, we love our doctor, we love our provider, we love our nurse, we love them. So that's important. So I'm going to give you one last movie. I know I gave you a lot of movies today. I hope you enjoyed them. But Tom Peters, when I was getting my MBA, was one of the, kind of like a mentor. Do you guys know Tom Peters? Because he's not a physician, he's a business person. So Tom Peters, and actually he's got a website, and he's got tons of stuff on business. He does some healthcare stuff and some non-healthcare stuff. But brilliant guy. And he's based out of actually California, but he had given us some lectures when I was getting my MBA. And he did one on patient satisfaction, patient experience. He was way ahead of his time. He usually is with the stuff that he does. And he talks about Preskini back in early 2000s.
None. None is a very small number. None, zero, zip, nada. Very small number, right? Well, there's an organization called Preskini, and they study patient satisfaction in hospitals. One big study they did, 225,000 hospitals, 139,000 patients, and they asked people what was important to whether they had a good experience in the hospital. And so they got 1,000 ideas, and then they put together a list of the top 15 things that determined patients' satisfaction with a hospital. Here's where the none comes in, okay? The top 15 factors associated with whether or not you were happy with the hospital experience that you had. Guess what? None. Zero. None of the 15 had anything to do with whether you got well or got better. Every single one of the 15 had to do with the quality of the interaction with the staff, whether people treated you kindly, whether they hadn't treated you kindly, the morale of the staff. But I just love that. I mean, that's, not to say it doesn't matter whether you get well or not in a hospital, but relative to people running restaurants or anything else, what people remember is the quality of the human interaction, much more, frankly, than the way that shrimp were cooked. Now, this was stuff that came out of probably one of the best hospitals in America called Griffin Hospital. It's up in Derby, Connecticut. And the lesson that Griffin people took out in a book was what they said, and again, this is so important to your life and mine. Kindness is free. And here were the words that they used. They said there is a misconception that supportive interactions require more staff or more time and are therefore more costly. Although labor costs are a substantial part of any hospital budget, the interactions themselves add nothing to the budget. Kindness is free. Listening to patients or answering their questions costs nothing. It can be argued that negative interactions, alienating patients, being non-responsive to their needs, limiting their sense of self-control, can be very costly. They become angry, frustrated, frightened. They may become combative. They may sue you. But what I love this is, years and years ago in the quality movement, we learned quality is free, and it wasn't only free, but if you do quality right, you save money. And what these guys are saying in the world of hospitals is an incredibly difficult world is, number one, the thing that patients remember, and I'm not arguing against helping get them well, they remember the quality of the staff interactions, number one. The staff can understand, hopefully understands, is motivated to understand that kindness really is the key. And then this wonderful one, kindness is the key to happy patients, and kindness saves money. Doesn't get a hell of a lot better than that.
Questions?
Okay, guys, we're so shocked. We learned so much. Yes, Tom.
I had a question going back to you talking about the shift towards the electronic feedback and scheduling and this whole drive towards technology. And would you say that's hospital systems responding to the surge in technology from the patient side, or are we driving more of that through our shift towards that? Like a chicken or an egg, for example.
I guess my answer to your question would be yes. And the reason why I say that is because, you know, we're driving the electronic medical record and the database and things like that. And I hope I'm answering your question. You'll tell me if I'm on point with what you're saying is because we're accumulating all this physician data or this patient data that we're putting into this database. But the ultimate goal is for better patient care in the end. So one of our strengths where I am is we use an electronic medical record. We use Epic. But we have every provider under the sun in Nemours. So if I have one of my patients that sees me, and then they go to another doctor in my building, in our group, same day, next day, my note comes up. So they know they don't have to try to get on the phone with me. So that's better patient care. I think what's going to happen ultimately is you're going to go with your cell phone to the ER. Hopefully you won't have to, but if you ever have to go to the ER, and you're going to have a bar on your phone that's going to have your medical record there. So this way, if you come in and you really are not in the state of mind that you can give answers on what medicines you're on or what your medical history is, they're going to just go ahead and put that down, and on the computer is going to come up that you're on a seizure medicine and that you take this medicine or that medicine. This is your history. This is how old you are. You know, that was especially even when a patient is not receptive, comes in comatose. Comes to the ER, no one knows anything about this patient. They're not going to get the greatest care because we don't know their history. History is so important. But now it will come in either on your phone or on your license where they swipe that strip in the back of your license or something like that. So if I think I'm understanding your question right, I think it's on the front end it's going to be helpful because of that shared communication, and on the back end, so it's for the patient and for the doctor. So it's going to help the healthcare system totally, which should, again, improve quality. Does that make sense?
Yeah.
Did I answer your question, I hope? Okay. Yeah.
So I know that Medicare and Medicaid has been pushing towards bundled payment systems for a lot of like cancer treatments and things like that. Do you think that's going to be a huge concern of the quality of care because, you know, they're paying the same no matter what type of treatment it is, as long as it's within that certain, like let's say radiation, no matter if it's what form of radiation, they still get paid the same?
So did I tell you not to ask me anything I don't know the answer to? No, I'm just kidding. So you know, that's very interesting. And the reason why I say that is that, first of all, as we go from volume to value, like I said, right now with us, I get paid every time I take a patient to the operating room. Okay? And of course, I make my decisions based completely on clinical, and it's the right thing. We hope everybody does that, right? But maybe not everybody does do that. If there's an incentive for me to take you to the operating room, I may take you to the operating room, you know, where you could have gotten better just with rehab or with a little bit more time. And again, I'm not suggesting that happens, but I got to believe some of that happens. So with these bundle payments and with us going to value and things like that, the question is how is that going to affect medical care? Well, if you look at it, again, we're going to an employed system. So are we going to get to socialized medicine one day? I don't know. But clearly, more and more doctors are employed now, where years ago they weren't. And so at the end of the day, they're going to get a salary. And then, so it's not going to matter. You know, the surgeon's going to hope that they're actually incentivized not to take someone to the OR because I have more free time, per se. You know what I'm saying? And again, so when we look at it globally, that's the direction we're moving in. We're going to have more employed physicians. We're trying to here's another thing that is an interesting concept, and I'm a firm believer in population health. I think that we have to, you know, I always say, you know, an ounce of prevention is worth a pound of cure, right? So if we take care of people from the time they're born, make sure that they get their immunizations, make sure they see their physicians on a regular basis, make sure if they have a disease that we're staying on top of it so that they don't run into problems to come into the hospital. And so if we can prevent disease, and that's where this big change is coming for physicians, is rather than, we're in the business of curing people, but now we're being asked to be in the business of keeping people healthy, because we don't want to get to the point where we have to cure them. Do we know how to do it? Yeah, we'll know how to do it. But that's a whole different concept for physicians now, is thinking about just being healthy, staying healthy. And that's what population health is. You guys are aware of what population health is? So you can take populations of people, and basically the insurance companies are going to say, we're going to give you X number of dollars, and you're going to take care of this 100,000 people. And if you are able to keep them healthy, keep them out of the hospital, keep them without medicines, and you make money at the end, you get to keep that extra money, because we're going to pay you the same amount no matter what. If they're sick and you're operating like crazy and so on and so forth, well, it's going to cost you more than the cost to take care of the patients. And I think that is the direction that we're starting to go in, is more of a population-based health a look, and more bundled payments. Again, this may be more than you've asked, and great question, so thanks for that, but there's no more money. That's the bottom line. The gross national product for healthcare is like 20%. And our population's growing, our population is aging, and we don't have any more money to take care of all these people. So if we don't keep them healthy, there's no way the system's going to be able to take care of them when they're old. Does that make sense? Any other questions? Yeah.
Do you think too much of a focus on patient satisfaction can actually improve the quality of care? So, for example, like one of the projects that we're working on right now, they just changed 3 questions in the HCAP survey in the pain management section because they think that it was hampering or maybe kind of influenced the way the doctors are prescribing painkillers and opioid. And I've heard it a lot from either nurse practitioners or physicians saying that patients would use patient satisfaction to drive to get more painkillers.
Yeah. So that's a big problem and possible misconception from our ERs mostly, because patients come in to get their opioids through the ER, and then and they want to get, because I hear that a lot. I'll tell you a funny story. So I'm sitting at my desk, and I had my administrator, my admin says, this woman has called. She wants to speak to you. She's from the Drug Enforcement Agency. And so I was like, okay. So they put it into my office. I closed my door, and I'm like, yes, what did I do? And the lady said, do you give lectures on patient experience, patient satisfaction? And I said, I do. And she goes, okay, then I got the right person. I got your name from Doctors Hospital in South Texas, that they told me you give a patient experience lecture. And as we're trying to combat the narcotic issues, and we're giving lectures about opioids and narcotics, we were hoping we can start giving in the same venue a lecture about patient experience, because I believe that if this is not 100%. There are going to be people that are drug seekers and stuff like that. But I believe if you educate people and you treat them right, I think that if they don't get the narcotic that they come in for, but you've given them an alternative that works for them, I don't think they're going to give you a bad score. So again, are you going to have those patients that will potentially drug seek and try to do that and potentially affect your score? They probably won't be filling out your survey because they're probably not going to get it. You know what I mean? Or if they get it, they're probably going to throw it away anyway. But again, I think if you follow these steps, or you do these things that improve the interaction with the patient, they're going to like you, they're going to give you good scores, and they're not going to give you bad scores because you didn't give them what you wanted. I've had patients, now this is not to the level of a narcotic or drug-seeking patient, but I've had patients come in and say, look, Johnny's got a sinus infection and I want an antibiotic. And I look and I said, Johnny doesn't have a sinus infection, he's got a viral infection. This family's come in thinking, I'm coming into the doctor, I want an antibiotic. And so they go out without an antibiotic. My scores are still pretty good. And why is that? Because I explained to them, first of all, this is a viral infection. And so it needs 5 to 7 days. All the drainage is clear. I think he or she's going to get better just with some antibiotics. Maybe you want to use some saline spray in the nose, just little things like that. And let's hold off on the antibiotics. And if Johnny's not better in a few days, give me a call back. I actually give all my patients have my cell phone number. My cell phone number is on my card. All my patients get it. Matter of fact, I've had doctors say, "Are you kidding me?" Do you know what's amazing? I had a patient that came in, and I looked at the patient, and I said to the mother, "Why didn't you call me? You had my cell phone number." You know what she said? "I didn't want to bother you on Sunday." I said, "This is the reason why I want you to bother me. You know, that's the reason I give you it." So they're actually very respectful. And I actually have a fair amount of patients that are underinsured or uninsured. You know, where I work, we take everybody, regardless of your ability to pay. So I have many patients that have insurance. I have many patients that have Medicaid or underinsured. They all get my cell phone number because it's on my card. I hand out my card to everybody. And so again, it's that human interaction like we talked about. It's that trust. You know, if Dr. Justin says that we don't need it, then we trust him. He's saying you can call me 7 days a week, 24 hours a day. And they don't abuse it. It's amazing. So, yeah.
Do you spend a lot of time training people to do this and like educating and training? Because I feel all this comes down to like the education and training. Is that something that
I do. Yeah.
Is there a portion of your budget that goes just to educate and train physicians that they're doing this?
So yes. So actually, what we've done when we first rolled this out early on, we actually started something called the GO project. It probably should have been called the GOO project. We took our high volume practices, GI with a G, otolaryngology for ear, nose, and throat, ophthalmology, and orthopedics, so GOO. And what we did was we put a psychologist in the clinic, or someone who was very good in patient experience, and I actually did some of the work myself. And I would go and I would shadow the physicians. And then when we come out of the room, and I'd say, "This is what you need to do. This is what you're not doing right." I've also given this lecture to them. I mean, I've gone to Delaware Nemours, Orlando Nemours, and I give it nationally at other places. But in our own institution, I always want to take care of my own home institution first. It's like when I was younger, and I grew up in New York and Long Island, and we'd have a bad snow day. And I'd go run a shovel so I can go make some money and shovel some driveways around my neighborhood. And my father would say, "Where are you going?" And I go, "I'm going to shovel driveways and make some money." And he goes, "That driveway first." And so, you know, you take care of my father's driveway. He didn't pay me for it. That was part of my payment to live in the house, right? And be part of the family. So same thing for Nemours. I mean, you know, so I've given this lecture a bunch of times. We've shadowed. We have a psychologist. And actually, we still do that. We actually have a whole program that's run by one of our psychologists where we have patient experience. And it's actually changed because when we first started, matter of fact, this is very interesting. So about 15 years ago, maybe a little bit less, we started something called the Physician Satisfaction Committee. It was me and one of the neurosurgeons up in Delaware, in the Nemours in Delaware. People used to say, "You need patient experience." And I said, "No, patient satisfaction." I said, "No, physician satisfaction." Because if our physicians are happy and they do a great job, they're going to take care of our patients, right? So we want to think about that and make sure that they're being taken care of. So this whole thing from 15 years ago to now with patient experience now and then physician satisfaction, physician burnout, we have a whole wellness program, and then we have subsets from that. And patient experience is one of the subsets. But we do put a lot of resource into that. As I showed on my first slide, it said, you know, patient experience matters. So we do have two positions, one in the north and one in the south, where we have someone that part of their time, it's a physician or a clinician, that is our experience officer. So yes, we do, it matters, and we do put resources into that because it's important.
Do you depend on the medical school to train your physicians for this, or when the physician, like when the resident fellow come to Nemours, is there like a training session to kind of, you know, welcome them into this culture? Because a lot of times these physicians are spending a lot of time studying, and they might not have as much interaction. Do you spend some time like kind of pre-training them before they kind of go in and start doing this?
So we don't have a medical school. Nemours is not a university. Now we have affiliations with medical schools. Right here in town, we have affiliation with the University of Florida and Mayo Clinic, and so they do send residents to. They send residents to Nemours for their training in pediatric, whatever subspecialty they're in, and so they get the experience based on, you know, that interaction with our doctors and knowing that that's our culture, and so they're intertwined in that as our residents, and their expectation is that they. So do they get formal lectures on this? Not at that level, because they're there for their clinical care, but it's all continuum a part of that. And so they learn some of that stuff, and they see, because they know we do surveys, and they know the things that we want to do. Now, myself, and there's many other people out there that, I don't know about many, but there's a fair amount of people out there, I'm sure, that give patient experience lectures at the medical school level and in the residency programs and stuff like that. I was down at the University of Miami last January and gave this lecture to their residents. They have a big ENT program, and they asked me if I'd come down and give this lecture. And so we're trying to give that to the residents now because, again, this is something that you don't learn in medical school, but it's eventually probably going to be pushed down even into medical school. There's a lot of stuff that we don't. When I went to medical school, we didn't do any of this kind of stuff. I mean, it was something that you just kind of learned along the way as you moved up. Great question. Any other questions? Yeah.
Hi, I shadow some physicians here in Jacksonville, and I come from a different background. And I've noticed that a lot of providers spend a lot of time not only taking care of patients, but like having EMRs to fill out, and also doing a lot of bureaucratic work. So do you think that we can use technology to not only improve patient satisfaction, but also provider satisfaction?
So yes, technology is a benefit and sometimes a curse. And so, first thing is you have to educate people how to use the technology. And so once they use it and they know how to do it, it tends to be, becomes intuitive, and it does help them. It makes it quicker for them to be able to accomplish the things that they want to. So we do that. I mean, we do, but I'll tell you, it's amazing. So and we have a lot of support with our IT department, and we've done a lot of things where, all our docs have cell phones and they have laptop computers and things like that, so try to make it easier, and we have a lot of applications that they can use to try to make their job easier. But the bottom line is, one, you have to learn how to do it. And then what they do is as you know, that every so often they do a refresh. And then all of a sudden, so all the stuff that you've learned how to do, it may be just small things. Now you have to relearn the process. But that's part of, that's life. And that's what I tell our docs too, is I said, I told our docs to get comfortable with the uncomfortable. It's change. You have to be comfortable with change. It's the only way we're going to succeed, because the only thing that's not going to change is change. It's going to change. And so, yes, I think that it's beneficial. There's a lot of things that we use via technology which has made our life a lot easier. There's no question. Except when it doesn't work and you're working on it and you're trying to get done, and all of a sudden it's like, the computer's not working. Can someone get me an IT person? So. But yes, it should help. So, other questions? Yeah.
Do you see any trends in the future that will help address consumerism and patient satisfaction and increase those scores?
I think we're getting there already. Again, first of all, if you incentivize things that you're trying to accomplish, it's human nature. People are going to try to be successful at that, right? So as we incentivize, and now we're incentivizing in a bigger way, we're going to get the results that we need to. One of the other things, which is, again, this is almost a whole lecture in of itself, is we're in like this generational. I mean, you have your baby boomer. I'm a baby boomer. I'm in the last year, 1964. Now you know how old I am. I'm the last year of the baby boomer generation, 1964. I'm proud to be a baby boomer. But, there's more millennials now in the workforce. And it's a totally different. I was at a lecture once, or it was kind of a meeting lecture, but they were talking to us about generational differences, and they were talking to us about what millennial wants and so on and so forth. And I get it, but it's also got to be it's got to be, as I respect I respect every generation and the way they act, but they also have to respect the other generation. You know what I mean? And so it's teamwork in that regard. And when you're a physician, in my generation, when I was going through my residency, I mean, I could tell you stories you wouldn't believe, because we got yelled at. Getting yelled at was just part of what you did. I mean, you took it, because that's not acceptable anymore. You can't yell at people in the OR. You can't yell at people. We used to have doctors that would throw stuff. They'd get frustrated. Like I said, I can tell you stories that you wouldn't believe. But we just, you just let it roll off your back, because you knew that that was our training. That was the culture at the time. And it's funny because now residents have work week. They have work hours. So, that came out actually, I don't know if you know how that all came out. That was from the Libby Zion case. So up at Cornell University, there was a pediatrician, and she was on call overnight, and then this patient came in, and she didn't have a good night's sleep, and they felt that the patient actually had a bad outcome because of a sleep issue. And that's when they started in New York, they started to roll out work hours, limitations for residents and stuff. And I remember, I was a resident at the time, and I remember my chair had us all paged. There was an emergency meeting to come down to the main hub where we did. I did my residency at New York Eye Near in Manhattan. And we all came down here, and he went and asked everybody, does anybody know about work hour restrictions? Because we used to work 100 hours a week. He said, you know anything about work hour restrictions? And we were like, well, we heard about them. He goes, no such thing as work hour restrictions. This is your education. So, I don't want to hear about it. And so we continued to work the number of hours we did because that was the expectation. That's what we did. Now, it's funny because there's some research about that because they look at now sleep-deprived versus unsleep-deprived. They actually do some, in sim labs, compare doctors that are sleep-deprived with some of this endoscopic stuff. And they're actually finding there's really no difference. Actually, one study that they found is the sleep-deprived physicians knew they were sleep-deprived because they were so tired that they actually concentrated more, because they, what I'm saying? That the outcomes were as good, if not better, than the ones that were not sleep-deprived. Now, again, sleep is so important, I'm not suggesting that you do that. But my point being is that, there's just it's generational differences. The world is different now, but we do have people that have lived in the different times and the different generations. We have to respect that and work together to get to the right place where we need to go.
I got 2 questions.
Sure.
Number 1.
Is she allowed to ask questions?
You're the chief medical officer, and then you represent the physicians, and most of our students are not physicians, so they're going to work in the administrative part. What would be your advice for the future hospital CEOs, COOs to work effectively with the physicians?
So that's a good question. So first of all, I would say number 1 is to be inclusive. One of the things that a lot of physicians feel is that they're not included in decision making, and that it's done to them, not with them. Matter of fact, I a lot of times tell people that when I generally do things in a certain way, in a certain manner to get to the end outcome. But the first thing is that I ask people for their opinion. And if they're able to give their opinion, even if I don't go the direction that they would like to have gone, and I explain why I chose the route that I chose, they end up being okay with that. The problem is they don't like when something gets rolled out. They didn't know anything about it. They had no opportunity to go ahead and participate or contribute into that. And so they're feeling like it's being done, and then you get really a lot of pushback. So the first thing is you have to include. Second thing is that you have to share with people the different options that you're going. Third thing is once you make your decision, you need to share why you made the decision that you did. I also tell people that we're always improving. So just because I make a decision doesn't mean that's the direction that we're going to go indefinitely. We're still always measuring. We're still always looking to see how that decision panned out. Because if I make a decision and it didn't pan out very good, I don't want to keep on going in that direction. We need to go ahead and make a change. So again, I think that's how you get buy-in for the physicians, including them with the administrators. And in today's day and age, there's a lot more physicians that are going into administration as well. So you're really going to be sitting at the table with them as time moves forward. The other thing I think that's going to happen too is that there's been more and more medical schools that have opened. But there's not more and more residency spots that are open. So now there's people that are going through 4 years of medical school and they can't get a residency position. There's many that are now getting their MBA. There's some programs that are MD, MBA programs. And there are programs that are now going to be MD, JD programs. I think what's going to happen in the future, similar to what's happened in law, we have a lot of lawyers that never practice law. They go and they work in politics, or they do something in business, but they have that law degree as a foundation, and so it makes them very marketable in that regard, because education is essential, right? We always want to educate ourselves. So I'm I think that's what's going to happen with the MD degree. I think what's going to happen is a lot of people going to get an MD degree and will never practice a day of medicine in their life. They'll work for a drug company, they'll work for insurance companies doing risk management or peer review, or there's a million things that they can do. They may just be a consultant, but having that MD degree will give them that education or that foundation for them to be able to offer that additional expertise for companies that are looking for that. Look at Amazon. Why is Amazon going into medicine? You know what I mean? It's going into medicine because they're looking at the advantages that they can do with technology. And, producing, what Amazon does now, from my understanding, is they will, now, maybe this is Amazon, maybe this is Aetna and CVS. So what they'll do is if you have a patient who needs a throat culture, they'll send a nurse out, do the throat culture, bring it back, they get an answer if the patient has strep throat, for instance, and then you can call the physician and say, here's the result, I want my antibiotic, or they'll call the nurse practitioner. So again, they're looking at different ways that they can go ahead and provide medical care, and it's not even their space, but they're coming into that space. And it's okay, it's innovative. I always tell people that, one of the things you had another question you said.
Yes. The more general question, these are the future healthcare leaders. So based on your experience and your projections for the future, what kind of talent they needed or what kind of competencies they need?
So, I tell people that I love challenge. I think challenge is great. I like change. So I tell people that let me ask you this. And please, what's your definition of success? How about that? Can someone give me, I don't want to pick on anybody, so I'll wait for you to, does anybody have the definition? What's your definition of success? Anybody?
Driving that new Tesla.
Driving the new Tesla, okay. So that's, okay. Okay, go ahead.
Placing goals ahead of you and meeting those goals.
Okay. Anybody else?
Being happy with what I do.
Being happy with that. Anybody else?
I was happy and fulfilled.
Happy and fulfilled. So what's interesting is that, is there really a definition for success? It depends. Everybody has their own. There's some people that feel if they've finished college and have a very modest life and live in a nice house and able to feed themselves and whatever else, that may be success, and that is success. That's success for them, and that's great. What I look at success is, I think of lifetime success is the ability or the ability to get from the beginning to the end with self-sustainability, where you're not reliant on anybody else. So I'm successful because at the end of the day, I'm able to, obviously you have your family that takes care of you when you're a baby and a child, but getting to the point where I have the equipment to take care of myself, and if I have a family, take care of my family and move on. And then even when I go through retirement and into the end of my life, that it's self-sustainable. I can go to the end. So how do I do that? How do you do that? So I think it's very important to, number one is, I think, attitude. I have 7 principles that I think are the foundation for success. Okay? First foundation is attitude. I think you have to have a positive attitude. I think that positivity beats negativity any day. I've said to people, smile and the world smiles with you. Okay? And so if you have a positive attitude, that's great. That's the beginning of the foundation. Number 2 is being innovative. And this is all under attitude. So being innovative. You need to be on the front side of the curve. And so I'm going to tell you a funny story. So I like new technologies. I'm always trying to learn the next thing. And so there was a new procedure that came out. It was called balloon sinuplasty. I don't know if you've ever heard of it, but what they do is they take a little balloon, they stick it in the sinus, they blow it up. Now, I'm a sinus and skull-based surgeon. So what I do when there's a child who has a tumor, I work with the neurosurgeon, and we remove the tumor through the nose with little telescopes. And I go up to the brain. I actually remove the bone between the brain and the nose. And the neurosurgeon does what he needs to as far as if there's anything in the brain or in the dura. And then after, I actually take some flaps and some bone and stuff from the nose, and I close the defect. Okay? So this was sticking a balloon in the sinus and blow it up. I think I know how to do that, right? So this new technology came out. certainly has some good reasons to utilize it. And I got interested, and I said, I wonder how this is to use in kids. Is it safe to be done in kids, and so on and so forth? Some stuff was coming out in adult literature about the utilization. Even in the ENT Academy, there was some controversy of whether it was something that we should be doing or not, or, is it a farce by sticking a balloon and dilating open the sinus? So I went to Tennessee, which is where this company was that was one of the early adopters of making the equipment. And I took their one-day course because I wanted to make sure that I was doing all the right things that I needed to, even though, I opened up the sinus, I removed the walls of the sinuses. I don't think it would be a problem. I know where the opening is, right? But I went and I took the course so I could get the certificate. And came back, and I said, this is pretty interesting technology. I want to try this. And so I found a child who I thought would benefit from the technology. I got them to get the equipment to the operating room. And there was a number of other physicians that didn't believe that it worked and didn't think that people should be doing it, and they didn't really understand some of the things regarding children. Again, the studies weren't out there of whether it was safe or efficacious in children. So anyway, I got this child signed up, which is a whole other funny story, which is, and then I'll tell you the rest of the story, was, the mother said to me, I told her this is new technology, and she said, well, how many have you done? And I said, well, you wouldn't believe how many I've done. And so she said, oh, okay, I had done 0. And so, but then I told her, well, let me explain to you, this is a new technology and stuff, and then I do bigger surgery than this, and it's not a big deal. So I was transparent and open. Then she said, no, I trust you, Dr. Tristan, let's go ahead and move on. So the day of the surgery comes, and someone said to the head of the hospital at the time, I was, this is earlier in my career, so Dr. Josephson is doing non-FDA approved surgery in children, and we have to stop him. And so I get to the OR that morning to do my case, and the nurses said, I'm sorry, Dr. Josephson, you can't do this case. And I said, well, why not? And they said, well, we were told from hospital administration that this is not FDA approved surgery, and we certainly can't do this in a child. So I said, okay. So I said, well, let's hold everything. Let's not send the patient home. Let me go down to administration and go and talk to them. So I went down and I met with someone in administration, and I said, here's the story. This is what I'd like to do, and so on and so forth. And they said, well, we understand that this is not FDA approved. And I said, hold on, and called the company. And I said, this administrator would like to know if your balloon device is FDA approved for use in children. And I put them on the phone, and they said, yes, this is FDA approved. Here's our number. You can go ahead and look it up. We're FDA approved. So I hang up from that. So then he goes, well, you never took a course. I said, oh, I took a course. This is the date I took the course. Well, you never brought your certificate to the medical staff office saying that you do this. I said, no one ever asked me. I'm the first one to do this procedure in this hospital. But if you like, I can run over to my office. It's sitting in a file. I'll give you my certificate. So I went, and again, for me, who does much more than this, to be told I can't stick a balloon in someone's sinus kind of seemed like a joke. But I understand all of that, and again, respectful of that. So I went and I got my certificate. We went and did the case on the child, and she did great. So the reason why I share that with you, that story is that, you want to be innovative. I always like to be on the front side of the curve, but you also need to do things correctly. You need to be honest with people, tell people what you're doing. I took the course. I could have not taken the course, but I knew that was the right thing to do, especially for a new technology that wasn't out there. And this way I had the certificate to show if someone asked me, which they ended up asking, to say, yeah, I'm certified to do this, and I can do this. What's interesting is we wrote an article back in, I think it was in the late 90s, maybe early 2000s. The article came out about safety of balloon sinuplasty in children. I was a co-author on that paper. It was the first paper that came out in children on that. And actually, it's one of the more common procedures that are performed now in children for sinus disease. And so, if I wasn't innovative, and I wasn't trying to reach the next thing, I would have never participated in something like that. I would have never brought something new to market. I brought a lot of things that are new to market. And it's because I was willing to, take the risk. So this is all part of attitude. Positive attitude, being able to take risk, being innovative. Those are all, and having determination and drive. So I always know I want to get to that end. And all of those things are attitude. And I think that helps to set up. And that's the foundation of success. And I've always actually gave the commencement speech at my undergraduate university back in 2015, and that was the basis of my talk, was my 7 principles. So second principle is education. Education is so essential. As I started this thing, as I said, you need to know more than you need to know, because you never know when you may need something, right? So I actually got that little tidbit from someone I know who actually was a folk painter. His name is Bill Nunez, absolutely brilliant guy, reads a lot. We had a lot to chat about. He said that his nephew stepped in a pile of ants. Now, he was a chemistry major in college, and so he knew about acid base and stuff like that. And in ants, the reason why your leg swells up is from the formic acid, right? So he stuck his nephew's foot in baking soda and water, which was a base, to counter out the acid, and it never blew up. He never got to swelling. And why was that? He said, well, I knew something more than I needed to know. I mean, what was the chance of that happening? Never happened again. So I always say, learning is just, should be something that's enjoyable and that you should want to do, and whether it's informal or formal. So we can't always do formal education. It's sometimes available. You're sitting here for a formal education, getting your master's in healthcare administration, but there's so much informal learning, either now it's so accessible education going online. You obviously have to make sure that the stuff that you're reading or learning about is good, proven, or correct. That's one of the problems with the internet is not everything is censored appropriately to make sure that it's good. But if you pick good things, my children, my son was having some problems with a math problem a few years ago, and we went online and we found this place, and we had this guy give him a 10-minute lecture on how to do this math problem. That is amazing. So it's so available, education, that there should be no reason why people don't want to continue to learn and make themselves better. And learning outside of your area of expertise. So, I don't, I know a lot obviously about medicine. I was trained in that. Then I went back, I got a business degree, so I know a lot about that. But I read about law. I read about so many other things because I want to know as much as possible. Knowledge is so important, it's powerful. It gives you a step up on anything that you want to do. So education is the second principle. Third principle is budget. And so, I'll tell you, so not everybody, now you guys are getting a master's in healthcare administration, so I'm sure you have at least somewhat of a business background. You don't need to know a lot as far as managing a budget or budgeting for yourself. One of the problems with our world today is it's so easy to get into trouble. Right? Because there's something that you see that you want to get, and you want to buy it, you got a credit card, you buy it, but you really couldn't afford it. So one thing is pay yourself first. Always make sure you're always putting away a little bit for your retirement, starting early on is when you can. And I understand people are taking loans out for college or graduate in school, but you can still budget. There was a book that I read, it was called The Richest Man in Babylon. Anybody ever hear of that book? So Richest Man in Babylon, basically the guy said, I can live just as well on 9 cents as in 10 cents. So he took 1 cent and kept on putting, he became the richest man in Babylon. And then after, once he accumulated some wealth, people were coming to him for loans. So he made more money on his money because he was the richest man in Babylon. So budgeting appropriately, having that kind of discipline to know, what kind of things do I need and what kind of things do I want. I always kid around with my kids when we'll go to a store and, they have those racks that are, circle. And I'll go, need it, want it, have it, want it, need it, want it, So I'm always kidding around saying, no, you don't need that. Let's talk about the things that you need, things that you want, and then you kind of balance through that. So that's, budgeting or finance is the next thing. Next thing is benevolence, giving back, paying forward. You should never not want to give back and pay forward. So when we're younger, generally, we don't have the finances to be able to make a nice donation somewhere, right? But we have time, or we can make time. So even at this age in my life, I still attend a lot of events that I give my time so that I'm helping to set up. I got a call today. I go to the Special Olympics every year. I actually bring my kids, and we actually help them set up in the morning. We help them break down the tables at the end of the day. We do the scoring we actually have a great time. It's really kind of fun to do that, and we're doing that. Think about how much it would cost to hire someone, even just to break down tables and to put up things and set up per hour if you had to pay. And so what do you do? You're really helping. And I think we also need to look at our communities that we live in and give back to our communities. So I think we need to see how we can be involved. So it could be financially by donating. It could be by volunteer work, like I said, or participating in things that continue to make the community develop and grow. So that's the fourth principle. The fifth principle is spirituality. So I always tell people that it's not a matter of it's not a matter of religion. It doesn't matter what your religion or beliefs is. It's just a matter of mindfulness and spirituality. Believing in something greater. Get you through some of the hard times. To recognize the things that are, how fortunate we are. I've done some mission trips in different places around the world and done some charity surgery. I went to India many years ago, and I was amazed to see, it was an eye-opener for me, how many people live there. Most of them, not most, but many people there are very poor. They live in a tent, and they don't know if they're going to get food that day. And I feel very fortunate. I'm very thankful. And so when I think about benevolence, I also think about, spirituality, I also think about being appreciative. And so it's not only that spiritual aspect of things, but I am very thankful I'm able to go ahead and stand here before you guys and give you a lecture and talk to you and get to know you a little bit and have this interaction. To me, I feel like I'm getting more than I'm giving. And so I appreciate that. And so I think that that's very, very important. Next thing is wellness. So again, I'm a very disciplined person. And so tonight, I will be on my BioFlex machine for 15 minutes. Before I go to bed, okay? So I used to go for a run when my times, and I do still go for a run often. Actually, a run which goes into the 7th principle, which is relationships. But I go for a run with my wife a lot of times. So we'll go and we run 4 miles together around where we live. And it's a great opportunity, but it's also a great opportunity to stay healthy as well. But it's also eating right, getting a good amount of sleep, drinking lots of water, right? Because most of our body is made up of water, right? So I'm always drinking tons and tons of water. And then also managing what you take or you consume, whether it's, it's okay to have, some people think you should have a glass of wine every night. I'm not sure I agree with that. But there are some studies out there that prove that a glass of wine every night would be helpful. But I think it's okay. Again, everything in moderation, I say. It's funny because I went and I got my physical exam from my physician a few weeks ago, and he goes, Gary, everything looks good. What are you doing? I said, you're not going to believe it when I tell you. And he said, what's that? I said, I eat right and exercise. And so he started to laugh. And so anyway, so health and wellness. And the last principle, and they don't have to all be used in a certain order, except principle number 1. Attitude is the number 1 principle. But the last principle is relationships. So relationships start as a foundation with your family or your spouse, and then grows from there. And you should always want to give more than you get. And so, like I said, these principles sometimes cross each other, but you should always feel like you want to give. But when you have relationships with people, it's a give-take. It should really be mutual where it's equal, but it's never exactly equal. But as you develop more and more relationships with people, you are able to give and get. And they may be in a different field than you, and there's things that you can collaborate on. And it just opens up the world of possibilities for what we started with is, what is success? And that's what success is, living by 7 principles. So.
Thank you very much. You really learned a lot. Well, I learned a lot. I didn't miss a word. And what I learned, the most important step tonight, I cannot yell at you guys.
Exactly.
Well, thank you very much.
Thank you. I appreciate it. Thank you, everybody. I appreciate it.